And welcome to the recorded lecture on xanthines and nonsteroidal anti-asthma agents. So this is going to be a very interesting topic. Xanthines, we'll talk about indications for use, which ones are out there, and then what type of patient populations you're probably going to see them as a first-line therapy, and then other ones as a third or fourth-line therapy. So when we're looking at these two categories, there are ways to aid or help different conditions when we're looking at it, but when we're looking at these things, I want you to think about what situations would these be used most commonly in, and that should help you understand when we're going to use them. So let's get started. All right, so xanthine indications, and this is the big one for adult patients. We're looking at COPD and asthma being the primary indications here. So between COPD and asthma, theophylline is the most common xanthine. So it's used for people older than 5 years of age. So they got to be greater than 5 years of age. So that's going to be the big thing there. Now, the COPD and asthma, it's one of those things where it does have some bronchodilating capabilities, and we'll go into the pathophysiology. It does have some of those abilities, but it does help with the respiratory drive to breathe. And remember, with this one, with xanthines, the mode of action is unclear, right? Let me circle that here, right? The mode of action, unclear, right? We don't know the exact mode of action on this one. But when we're looking at this for asthma and COPD, it's the second or third line agent. Second or third line agent. Let me circle that a couple of times, right? It's a second or third line agent for COPD and asthma, right? It stimulates the drive to breathe and strengthens the diaphragm contraction. When we stimulate the drive to breathe, that helps us endure, right? Gives you more endurance, and it helps give you some more strength for your diaphragmatic excursion, so it can help you during an exacerbation or cope with accessory muscle use at baseline. So that is a helpful thing there. The third condition, the third indication on this list is AOP. If you're like, I don't remember what AOP stands for, it's apnea of prematurity. So these are babies that were born premature. The more premature they are, the more likely they are to have apnea prematurity. So in utero, you have fetal breathing motions in utero, and we'll talk about that in perinatology. So you have fetal breathing motions in there, but they're not for sustained drives. They're there to help develop the tissue, to help pull fetal lung fluid, to pull amniotic fluid in and out, to help develop and stretch that lung tissue to help you. But if you're delivered prematurely, let's say you're only delivered at 26 weeks of gestation, 30 weeks of gestation, right? Your lungs are still underdeveloped. And so your drive to breathe is not there. Your brainstem's not ready for that stimulation and continuous drive to breathe. So the smaller a baby is, the more premature the baby is, the more likely they are to have apnea prematurity. Pretty simply, they usually have a central apnea, right? It's like when we talked about sleep apnea, how we have central, obstructive, and mixed. Well, these babies are more likely to have central apnea. And to some degree, they could have a little bit obstructive. So there could be a little mixed action going in there, but primarily their brainstem's not set up for that drive to breathe yet anyway. And so that's what we see there is apnea prematurity. However, unlike COPD and asthma, it's a first-line treatment for that, right? So before we take this premature baby off the ventilator, one of the things that we might start is giving them caffeine in an IV dose, right? We do a caffeine IV dose, and it's called caffeine citrate, right? Caffeine citrate. And so that's what we give IV to help give them that drive to breathe and strengthen their diaphragm. So this is something we'll start even before we extubate these babies, because we know the respiratory stimulation when we take the ET tube out is going to be lower. So that's why some of these kids might need CPAP or high flow, non-invasive. But that first-line therapy of caffeine has been shown to help with that drive to breathe. So xanthine indications, summary, right? Xanthine indications for people over 5 years of age with COPD and asthma as a second or third line treatment. the mode of action is unclear, and it's a first-line treatment for apnea of prematurity on babies. So your next clinical rotation here in the neonatal ICU, you'll probably see a lot more babies that are on caffeine. Remember, theophylline is the most common for COPD and asthma, and it is not used in an acute exacerbation when we're talking about COPD asthma. We're not using it in an acute exacerbation as it has a weak bronchodilating effect. So someone comes into the ER with a COPD asthma exacerbation, that's not when we're going to pull out the theophylline. It's more of a continuous long-term medication situation. It's got to be built up in their system with their serum concentration. So we're looking at it as more of a maintenance therapy than a rescue therapy in the COPD asthma situation. So theophylline is a natural metabolite of xanthine, so that's where that comes from, and it has a methyl attachment to it. So that's where we have the methyl xanthine, right? The methyl xanthine, right here at the top. You're like, what is a methyl xanthine? Well, I just explained it. It's a natural metabolism. Theophylline, anyway, is a natural metabolite of a xanthine. So the methyl attachment is what we're looking at there, right? So caffeine will trigger or drive the CNS stimulation. Well, if we stimulate the central nervous system, then that will increase ventilatory stimulation, right? And that ventilatory stimulation should help increase the drive and the strength of breathing, right? That diaphragmatic excursion, because we're looking at this hitting the brainstem. And remember from pulmonary A&P, the two areas of your brainstem that control breathing is your medulla oblongata and your pons and your pontine center. So once we have that increased drive to breathe, that should help these patients overall. So these are the general physiological effects that you'll see. You do have CNS stimulation. CNS stimulation now, when we're looking at this, what does it stimulate, the sympathetic or parasympathetic nervous system? Right? Sympathetic or parasympathetic? Well, hopefully you said sympathetic because it stimulates it to breathe deeper and more regularly, right? Because remember, that's going to be our fight or flight, that's going to be that response. So it does stimulate that sympathetic nervous system. So CNS stimulation, it's sympathetic. It will cause cardiac smooth muscle stimulation. Of course, some of you know this if you've taken a lot of caffeine before. Hopefully you haven't taken too much, but you never know. But that can also be something that we see there as well, is that cardiac muscle stimulation. So it can increase heart rate and blood pressure in some patients. Diuresis, right? Of course, some of you know this that are, avid caffeine enthusiasts out there, that it can work as a weak diuretic as well. So you will see some fluid, they could see some fluid diuresing in some of these patients. The other one here is bronchial and vascular motor smooth muscle relaxation. So once we have that bronchial and smooth muscle relaxation, that's what gives it some bronchodilating effect, right? Now remember, this is still only a second or third line treatment for asthma COPD, right? But you do have some smooth muscle relaxation, some bronchodilation, right? And so that helps out with vascular smooth muscle and bronchodilation. So vascular smooth muscle and bronchodilation. And then finally, you're going to have peripheral and coronary, right, vasodilation. So that's going to happen. So why does caffeine help headaches? It'll cause cerebral vasoconstriction and limit the blood flow going in there. So that should help with headaches. And that's why you see caffeine in those high-dose Excedrin medications, those high-dose headache medications as well. So when we're looking at methylxanthines, remember the mode of action is unclear. The mode of action is unclear. We don't know exactly the pathways that it uses. We know its effects, and we know what medications give us those effects. So and then what the chemical structure is, but we don't know the exact pathway. So the mode of action is unclear with xanthines. One of the things that we know that happens is they do inhibit phosphodiesterase. They do inhibit phosphodiesterase. So when we're looking at these, one of the other things that we have to see here is it causes that smooth muscle relaxation. Smooth muscle relaxation because it's inhibiting that phosphodiesterase action. The next one on here is that it will block adenosine. It blocks adenosine. Why is that important? Because theophylline is a potent alpha-1 and beta-2 inhibitor. So if it blocks alpha-1 and beta-2 stimulation, then what happens? Alpha-1 and beta-2 stimulation, then it will block smooth muscle constriction by blocking alpha, right? Because remember, alpha is one of those things that could actually cause bronchoconstriction. So therefore, we're going to have some bronchodilating effects as well because it is blocking that adenosine pathway. So we have some advantage there. It may affect prostaglandins, not a lot of evidence there. It may affect calcium especially. So when we're looking at calcium, that's what will eventually release epinephrine in the sympathetic nervous system, right? Which then releases and so on and so forth, right? So when we're looking at that, the calcium was the big thing that started the neurotransmitter release in both the parasympathetic and sympathetic. But here, if it affects calcium, then it will release epinephrine in your sympathetic nervous system, right? So that can be a potential a side effect that you see there with that heart rate increasing. It does show that it increases ciliary beat or mucociliary escalator clearance. So that is another advantage, is airway clearance could be something that is a potential benefit for it as well. So that ciliary motility, that ciliary activity, and then finally a catecholamine release. And the catecholamine release can be pretty significant because remember, it causes coronary vasodilation, it causes peripheral and coronary vasodilation and cerebral vasoconstriction. That catecholamine release can easily cause cardiac vasoconstriction as well. The arteries that supply the muscle to the heart, the myocardium, like the anterior intraventricular artery, those things can have vasoconstriction with it. So do look at that. It does have some of those things that can happen with catecholamine on an extreme level, but in general, that catecholamine release should be pretty minor and shouldn't have to cause any bad side effects, significant side effects, I should say. All right, apnea prematurity. I love talking about apnea prematurity. You're going to see this a lot in the NICU, and you'll walk through a NICU, and most NICUs, they're full of preterm babies, right? Sometimes they're term, or post-term, but a lot of them are preterm. And so what you're going to see is a lot of these kids that are either on a vent on room air, they're on a CPAP or non-invasive on room air, right, where they were just using 21% oxygen. Or they're going to be on a high flow at room air, or they might be on very low flow oxygen. I'm talking cc's, not liters per minute, but cc's, mLs per minute, right? Flow meters. So very low amounts, and a lot of them, they're on those things because of respiratory stimulation, right? If they have apnea, then they'll have a bradycardia. If they have apnea and bradycardia, usually the heart rate, the apnea and bradycardia, usually their saturation will drop, their heart rate will drop, and then they're going to have what's called an A, B, and D episode, apnea, brady, desaturation, right? And we try to actually count the amount of apneas, bradies, and desaturations that these kids have. And that's something we trend, that's something we give in report, because it tells us where this kid's head is at. And so when we give respiratory stimulation, when we give baroreceptor stimulation to these patients, whether it's CPAP, high flow, non-invasive, invasive, it gives respiratory stimulation, it stimulates their drive to breathe. But they don't have that, right? They don't have that continuous stimulation. And that's why going from a high flow to a low flow oxygen might cause a lot of apneas, bradies, and desaturations because there's not nearly as much respiratory stimulation there, right? So they need that. So normal apnea for a baby should be less than 10 seconds, but periods of apnea can last up to 20 seconds on these babies. So when you set on a neonate ventilator, right, when you go out to your NICU rotation and you're setting apnea mode, you're setting it for 10 seconds, right? You're setting that apnea mode for 10 seconds. On adults, we usually use 20 seconds, but those little guys, the neonates, the preterm babies, we'll use that 10-second. They can have periods up to 20 seconds, but when we're looking at this, the symptoms that we see, how do you know a kid is having an apnea bradycardia episode? Well, you'll see apnea and bradycardia. Usually it starts with the apnea, right? If you stop breathing, your heart's not getting gas, right? It's not getting oxygen, and then they'll desaturate, obviously, and their heart rate will slow down. So apnea, bradycardia, desaturation. So we call them the A's, B's, and D's. A's, B's, and D's. So we'll be given a report and we'll say, hey, what's their A's, B's, and D's? Oh, they had 3 of them earlier today, but after that I haven't seen any, right? So we'll count their A's, B's, and D's because if it's significant enough, it tells us different interventions, how aggressive to be, if they're getting better, getting worse, right? So how do we treat their apnea, bradycardias, and desaturations? How do we treat apnea prematurity? Well, that's pretty straightforward. We're usually going to treat it with heated high flow nasal cannula, right? Some respiratory stimulation, CPAP, respiratory stimulation. And if their A's, B's, and D's are severe enough, then we have to go to non-invasive or invasive mechanical ventilation. Those are respiratory treatment options. However, the first line treatment is going to be this one here, caffeine citrate, right? Caffeine citrate. So when we're looking at this, it's the first line treatment, and it does stimulate their drive to breathe. So theophylline can be used in theory, but caffeine is a more potent stimulant, and it will transfer, caffeine will transfer into their spinal fluid, which is what we want. We want it to go and stimulate their CNS more impactfully. Have you ever had some caffeine and you feel more awake mentally? Right. That's the whole idea here, right? We need to give these babies some caffeine, right? And to help stimulate their CNS to breathe. Sometimes you'll see them use caffeine with bronchodilators where they add theophylline into the pediatric ICU. But as far as apnea prematurity, that's usually going to be in your NICU, your neonatal ICU. So but when we're really looking at this, we're looking at where we're seeing this the most is going to be a first-line treatment for apnea prematurity. So xanthines are a first-line treatment for apnea prematurity in the neonatal ICU. When we're talking about methylxanthines, caffeine citrate is here. Caffeine citrate's the one that we use for kid, and then theophylline's the next one. Caffeine citrate can be given IV or oral, but however, in the NICU, obviously it's traditionally given intravenously. Theophylline is going to be in an oral dose or an injection. Typically, with my experience, your mileage may vary. It's going to be an oral therapy for those patients. Now, both of these, the caffeine sources here that you're looking at, both are alkaloids and they're derived from plants. So that's one of those things that you'll see with tea, right? Tea has a lot of caffeine, right? Cocoa has, not cocoa, but you'll see caffeine in a lot of different things, and they're derived alkaloids that are derived from plants. So the more you know. All right, so when do we use it, right? What are some uses? What are some things that we see, right? So let's talk about bronchospasm. So bronchospasm is an area, so this is, like I said, not an acute situation, but long-term situation. We can see it with bronchospasm. You can see it with pulmonary vasodilation, right? It's a known respiratory stimulant. It stimulates the central nervous system, and it does enhance ventilator muscle function. But the big thing here, understand this is starred, right? That star is there for a reason. It is not a first-line therapy for these patients. Well, so for a COPD, the ventilatory drive stimulate that it gives, what it'll do is increase nerve activity, But still, we need to do things like your inhaled corticosteroids, your long-acting beta agonists. We need to still do your bronchodilators, right? So we need to do those things first. If those things aren't helping manage that patient chronically, then a theophylline, then a xanthine is considered. With asthma, you could use things like cromolyn sodium first before you would go down a theophylline category. We do understand that it does cause pulmonary vasodilation, to go back up to this point up here. But when we do this, we're going to see that increase in cardiac output, which decreases pulmonary vascular resistance as well. So that will cause pulmonary vasodilation. So you're going to see that as a response to the increased cardiac output. You're going to have that pulmonary vasodilation to help avoid back pressure on the heart, to help avoid the heart from having any significant negative side effects. So how do we dose theophylline? Well, the step one here is to draw blood serum levels. If it's possible, the big thing here is to make sure that they have the right serum level of this medication. So it has a very narrow therapeutic range. If it's less than 5 mics per ml, they're not going to have any effect. It's not going to be helpful for that patient. When it's 10 to 20 mics per ml, that's when they're going to be in that therapeutic range, 10 to 20 mics per ml. Anything over 20 mics per ml, you're going to start to see negative side effects. So here is your therapeutic range, 10 to 20. Sounds like you need to know that, and you do. Anything higher than that, the first symptom that they're going to see is nausea, right? They're going to feel that GI upset. Then if they get over that into the 30 mic range, cardiac arrhythmias can start to go on, and then seizures, right? So we see those things in that step order. Nausea, then cardiac arrhythmias, then seizures, and anything over 40 mics per ml on their serum levels. The next part here, they have these on the boards. I'm sure they're still somewhere on those exams, is asthma. The therapeutic range is anywhere between 5 and 15. You're like, Derek, why is 5 have no effects, right? So it's less than 5 has no effects. But for asthma, anywhere between 5 and 15 is what you're looking for these patients. Remember, the definition for asthma means that their airway obstruction is reversible, so they might need a lower dose at baseline compared to COPD, where they're always going to be working hard to breathe, and that's that 20 mics, 10 to 20 mics per ml is what you're looking for there. But if it's, the big thing here is it is possible for the patient to pass that nausea state and go straight to that seizure phase. So it is possible to go from here to here, right? And so it has that narrow therapeutic window. So we got to make sure things like liver damage can make them retain a lot faster. And because they're not able to clear that drug as fast, it builds up in their serum and they can have more side effects from it. So we got to be careful about this. So being careful about this means monitoring their serum levels. There are immediate release forms, and they usually peak in 1 to 2 hours post-administration. So we'll give it to them, and then they'll peak 1 to 2 hours. But the most common ones are usually going to be that slow release form. That slow release form will peak in about 5 to 9 hours after you take it. But the big thing to remember here is the samples should be taken at peak times, right? So if they're taking immediate release form, then they need to check that serum level in 2 hours, 1 to 2 hours, right? Or an hour and a half, if you will, if you want to split the difference there. Or if they're taking a slow release form, they need to take that that serum level at this peak level, 5 to 9 hours, because that's when this concentration is going to be the highest in their bloodstream and have most potential for side effects. So what's safe for the patient? Not only when we give a medication, right? When we're giving a medication, we need to make sure that the patient doesn't have any significant adverse reactions. And taking these levels are going to make sure that the patient is safe, that they're not going to have a seizure when they take this medication at home, all right, or at school, or wherever they're at. So one of the biggest dangers with this is toxicity. So toxicity is going to be the big thing. If you have your book, go to 140 to page 143. So toxicity is going to be the big thing. It is metabolized by the liver. So watch for the patient's liver and kidney functions. Metabolized by the liver, and who gets rid of it? The kidneys do. So if a patient has poor liver or poor kidney function, it could really impact their blood serum levels. They could have much higher effects that could build up a lot faster in their system. And that's why we need to draw those samples, especially at peak hours for these patients. And then understand and educate them, hey, when this is going on, part of your patient education, when this is going on, if you still feel nausea hours and hours after this, if they have liver failure, if they have renal failure, we need to know that so that way we can make sure that they're safe when they're taking this medication. What disease process might affect this patient's theophylline? Well, let's talk about it. Hey, what about viral hepatitis, right? That inflammation of that liver can really affect it. And it does have a very narrow therapeutic margin, right? We already talked about that. So if someone has cirrhosis, if someone has congestive heart failure, if someone has these issues with their renal elimination, then we're going to see a lot more potential for issues on these patients. Probably way more significant side effects, more than just a headache, more than just nausea, more than insomnia. We're probably going to see a lot more significant side effects on those patients. So we got to be careful and make sure we know their history very well before we do this. So let's talk about side effects. So side effects real quick. Headache is going to be one of the easy ones because this is going to have some issues with excessive caffeine use. They can still develop headaches. They can develop insomnia, right? It impacts your ability to fall asleep. Right, take a lot of caffeine right before bedtime, not a good idea. What's going to be your ability to fall asleep? It really does impact your ability for sleeping. And then I think I have a whole nother lecture on sleep. So something you can check out there that I go into the pathophysiology of that a little bit. Nausea and vomiting, and that's going to be the one more common ones, is that upset GI side effect. Tachypnea, supraventricular tachycardia. I've told you guys all that story of that kid that was brought in from a high school where his friends dared him to drink 6 Red Bulls in a row, right? And he came in with really fast heart rate, and we couldn't tell if it was SVT or just a sinus tac that, buried the P wave. So that's one of those things that you could see with excessive caffeine use. Other things that you might see would be arrhythmias easily, hypotension, especially if their heart rate's going a little fast. They may not have a lot of time to recover and get good ventricular filling time. So you can easily see that. But the diuresis, you have to be careful, especially in bronchitis and cystic fibrosis, where that can lead to dehydration. And dehydration would be a very significant thing in bronchitis, cystic fibrosis, any type of bronchiectasis that you're looking at, because those secretions are thick and sticky, and if we dehydrate that patient, their potential for mucus plugging and workup breathing is just so incredibly high. So you do have to watch their fluid regulation as well. So let's talk about non-steroidal anti-asthma agents, but real quick, a recap of the Xanthines. There are 2 general situations. In the adult population, we're talking 5 years old and up, the general indication for Xanthines is going to be a 2nd or 3rd line treatment for asthma and or COPD. You do need to remember the theophylline is going to be the most common drug used there. And for asthma, the therapeutic range for the blood serum is 5 to 15 mics per ml. And for COPD, it's 10 to 20 mics per ml. The most common side effect is going to be nausea, and the worst, it could go all the way up to seizures. And we need to watch for liver and kidney issues with those patients. The next one is going to be caffeine, and it's a 1st line agent used for apnea of prematurity. And that's usually given a half dose BID or 1 dose Q day There's no evidence that says one is better, and those are derivative. They're alkaloids. They're derived from plants, and then we're going to do that to help reduce, to help stimulate the respiratory drive to breathe and the diaphragmatic force to breathe. So we're going to see the IV caffeine most commonly used in the neonate. So make sure you're summarizing these things as you're going along, right? What are some of the big things? And that's just me trying to help you out there. There's some things. Was I able to mention everything? No. But you can always rewind. Let's move on to non-steroidal anti-asthma. So when we're talking about asthma, there are two general types of asthma. There's extrinsic, where it's allergy, it's IgE mediated, and it's associated with more younger individuals or generationally new individuals. And then you have intrinsic asthma, which are associated more with adults, more generationally advanced individuals. So an example would be, for intrinsic, would be perfumes, cold air, dust. It might be even driven by a cytokine release from T cells, right? So those are things that can cause an intrinsic episode. So when we're looking at there's mechanisms of inflammation in asthma, right? All these, whether it's extrinsic or intrinsic, can go to a mechanism of inflammation. So allergic stimuli, right, from extrinsic, right, we'll have that mast cell release, So I think there should be a T here. Hold on. Mast cell release. When we're looking at that. And so that's really something that we're going to see with a lot of anti-asthma drugs, is trying to do mast cell stabilization. And remember, these mast cells are located in your lamina propria of the airways. So it's that middle layer of your conducting zone. And there's all that parasympathetic stimulation in there. And there's also the bronchial smooth muscle in there. So when these mast cells destabilize, they can really trigger the inflammatory release and cause that bronchospasm and cause that secretion production to go way up. So we got to be careful here with these allergic asthma patients. But there are non-specific stimuli that can trigger a reaction as well, right? We talked about antigens for extrinsic asthmas and intrinsic asthmas. Usually there's no antigen involved, and it's usually linked to something intrinsic, like perfumes, cold air, dust, right? Or a T cell release, right? So when we're looking at that, we got to be careful. Most incidents are primarily an allergic response that you'll see. So you'll see mostly allergic asthma, right? Or extrinsic asthma quite a bit. And so controlling their allergies, knowing their allergens, and knowing your triggers is the #1 therapeutic goal for asthma management in general. So once they know what triggers their asthma, then they can control themselves better and avoid a lot more side effects. So when we're seeing this, the allergic response is going to be the big thing, and making sure that you treat that allergic response as part of it. And like I said, Benadryl, any of those antihistamines could be part of their management as well. Do we administer those? Not usually, but just understand the big picture of it, especially if it's allergic response. We need to give them a medication that helps with that allergic response. So when we're looking at the mechanism of action, so this is sort of that mechanism that we see, we're going to have the airway inflammation occur, right? We always start with the inflammatory cascade. The inflammatory cascade leads to bronchoconstriction. Well, once we have bronchoconstriction, the airways swell, and once the airways swell, then the mucus begins to do its thing and create more mucus. Why do we create more mucus? Well, we're trying to flush out whatever allergen or whatever thing is in our lungs, whatever's causing it. We're trying to flush it out of our system. So when we're doing this, we're creating lots of secretions. Well, that secretions can then cause obstruction on top of having smaller radius airways from this whole bronchospasm thing, right? And then over time, the more and more someone has bronchospasms, every time, keep on having it multiple times a week, multiple times a month, so on and so forth, it leads to airway remodeling. right? It leads to airway remodeling. And this whole thing causes enzymes and mediators to be released, and we're just going to have ultimately airway remodeling. In fact, what's one thing, if you do some extensive research on bronchothermoplasty, you're going to see that the whole point there is to help to go into the airways and help demodel the airways. It's to help those smooth muscle that's been conditioned to be stronger and stronger and stronger over time. It's to help to demyelinate them and make them weaker. So when you do have a subsequent bronchospasm, it's not as strong, right? And so that airway remodeling is a big issue, and that's why we need to control this early on in life, because if we let it go, it can be pretty significant later on. So what are the three components of asthma? We have an acute asthma exacerbation, we have hyperresponsiveness, and we have persistent inflammation. These are your three primary components, right? You have that acute phase, you'll have that hyperresponsiveness to it, and then you'll have this persistent inflammation that goes on, right? Have you ever had a cough that continues on after the cold has gone away, right? That persistent inflammation. So in the first situation here where it's an acute asthma exacerbation, we're going to usually see these resolve spontaneously or with treatment, right? These ones can be managed at home traditionally when we're looking at this. So that's something that really helps us manage these patients. They're going to have that hyper-responsive state. So that's knowing their triggers, treating whatever is causing it. If it's something like giving them antihistamine, that's something we can do. And then managing that persistent inflammation that could be a part of remodeling the airway. So that would include using inhaled corticosteroids or long-acting beta agonists, right? And we'll talk more about those. What cells are involved? So when we're looking at the cell involvement, these are going to be different if we have an immune response. So now we're talking about allergic response versus that immune response, so intrinsic response. So when we're looking at this, that T lymphocytes, you usually will start the immune response. So there's allergic and immune, right? And right now we're in intrinsic, right? Immune response to it. So if it's an immune response, we're going to have it's going to be different. The mode of action is going to be different from the inflammatory response. So the helper T cell, right, will produce macrophages that are essential for the production of IgE, right? So that's that helper T cell. So when we're looking at this, you have your type 1 and your type 2 cells. When you go to your suppressor T8 cells, which is this part here, your suppressor T8 cells, that will inhibit the immune response to the allergen, right? It inhibits the, antigen. It inhibits the immune response to the antigen. Then when we get to cytotoxic T cells, they bind and destroy viral cells, right? Their whole point is to find the viral cells and destroy them. Whatever is causing the antigen response, it's supposed to bind and destroy. And finally, your natural killer cells, right? They're believed to target tumorous cells or cells infected with anything other than viruses. So the natural killer cells are the cleanup crew. Whatever else is left over, that's what they're supposed to do. But understand this whole thing, and I'm circling it, is that immune response. We just finished with the allergen response, and now we're in the immune response, more of that intrinsic asthma. So when we're looking at this, is this patient having a more extrinsic response or intrinsic response? And that can help us see where what we're looking at, what we're dealing with that caused their exacerbation. Once we know that, that can help us figure out better not only short-term but long-term treatments as well. When we're looking at these, antibodies and serum globulins or proteins will combine and react with that antigen, and they help buffer it. And that's what we're looking at here. So your antibodies, which are your B lymphocytes, right? These are little antibodies, right? You can draw a little ant next to there, right? And they produce plasma cells. Well, the plasma cells will help with, or part of this immune response. So they really do help. So the classes of antibodies that we're looking at are your IgG, IgA, IgM, IgD, IgE, right? And the big one here is going to be IgE, immunoglobulin E, right? And these have cytophilic antibodies, right? They heighten the immune response and they bind to the mast cells, and these are the effector, right? These are the things that we're looking at here. So this is that pathophysiology that really is going to heighten that immune response and bind to those mast cells and cause that bronchospasm. Now we're back to the allergic response, all right? The immunological or allergic response here. This one, when it's initiated, you're going to have that T lymphocyte that will interact with the macrophages. So your immune B lymphocytes, right, are your allergic response that leads to that antigen. Your allergic response that leads to that antigen being created. And then you're going to have IgE that will bind to the mast cells. Remember those mast cells hanging out in the lamina propria? The IgE will bind to those and release inflammatory mediators. And I've talked about this in our pulmonary A&P class before. So if you need to go back and review that, it would be your lower airway lecture from pulmonary A&P. But once those mast cells are triggered or released or destabilized, then they're going to cause all those things to release, including slow reacting substance of anaphylaxis. They're going to release histamine. They're going to release all those other things that will then cause that allergic response. So you're going to see this cascade be released when these mast cells are destabilized. When these guys here are destabilized, that's when bad things happen. So that's why we try to do things like give people mast cell stabilizing medications as an anti-asthma drug. Once mast cells are released, once they destabilize and they release their substance, the way I used to think about this when I was in school was like a skunk, right? When a skunk is mad, it releases something that's very unstable, right? So when you have a mast cell release, it's going to release a lot of things that are going to cause some things to happen, right? And it's very noticeable in some patients. The big things here are leukotrienes, prostaglandins, protease, histamines. The histamine is going to be the big one. That's why some people feel better after they're doing their antihistamines. Platelet activation factor, which makes everything sticky, and then even a cytokine release, right? A cytokine response. So all these are your allergic response when mast cells release or mast cells are destabilized. Well, let's look at their causes. So these causes, including vascular leakage, remember, we released a platelet activation factor. So we're going to have vascular leakage. We're going to have bronchoconstriction. So we're going to have some form of pulmonary edema, right? Pulmonary edema, bronchoconstriction, mucus secretion, and mucosal swelling, right? So with that mucosal swelling, what happens? Well, we have a higher chance of obstruction, not only because of the mucus swelling, but remember at this point we have bronchospasms, so smaller radius of the airways, and we're going to have more issues there. So that we're going to have an accumulation and activation of eosinophils, right? And then obviously airway damage. So eosinophilic asthma, if you've ever heard that term before, that's what you're looking at here, where we get a sputum sample and it's high in eosinophils. That's what we're looking at here. So that's the eosinophilic asthma. So we can actually get a sputum sample and see what that mediator is that's causing that, that's being released by that patient during that reaction. So here is a wonderful slide. And this slide is showing you, hey, if you have this antigen, right? We're looking at these antigens, right? Antigen versus a non-specific stimuli, right? So compare and contrast here. Antigen versus a non-specific stimuli. You notice there is some similarities in what's going on here, but we're going to see an exposure to an antigen that leads to an increase in airway inflammation. And then that attraction of lymphocytes, right? And that's going to cause the stimulation of mast cells. So when we have these mast cells released, that's when inflammatory processes are released, right? These inflammatory processes will then cause the severity of asthma. So here's your mast cell, right? So you have a virus, a fungus, dust mites, right? And then you're going to have this mast cell release, which then causes these mediators of inflammation, histamine, prostaglandins, leukotrienes, proteases, cytokines, right? So those are going to be released, and that's going to eventually cause your smooth muscle constriction, your vascular smooth muscle leakage, right? You're going to have that acetylcholine create more mucus now, right? So you're going to have a lot more issues. So when we're looking at this, this is going to be that pathway that we see with antigens. Now, if we're over here on the non-specific side, the non-specific cause side, this would be your intrinsic, right? Your intrinsic. So your cold air, your pollution, your fog, right? Things like that. So those would be those things. And they're usually sensory receptor stimulation that will then cause bronchospasm. So it causes that sensory reception on the epithelial lining. The epithelial lining there will then cause bronchoconstriction, and then you're going to release that mast cell destabilization, which then causes the smooth muscle constriction. So we're going to eventually go down to this area here, right? This area here. Nope. Nope. Right, so you see this whole connection there. So when we're looking at extrinsic, your mast cells and your T lymphocytes are going to be big parts there. But when you're looking at your non-specific or your intrinsic, which is cold air, fog, right, so on and so forth, it has a different pathway. It works on the airway epithelium. So you can see how treatments would be different for antigen-based stimulation versus non-specific stimulation. If it's non-specific stimulation, then we need to reduce that in the airway epithelial lining, inhaled corticosteroids, things to help do that as well. But if it's antigens, then that's going to be something that helps us where we do things like antihistamines and things that are mast cell stabilizers, those type of things that can really help those patients more significantly. All right, so now we're going to talk about non-steroidal drugs. There are 3 subgroups of non-steroidal drugs. There's cromolyn-like drugs, so these are mast cell stabilizers. Like, hey, that's the name of the game for this lecture, mast cells, right? So these mast cell stabilizers will prevent mast cell destabilization and therefore hopefully help prevent that bronchospasm from either happening or make it not nearly as severe. So with these, you're going to also have the second category, which will be anti-leukotrienes. And then the third one will be monoclonal antibodies. And these are becoming more and more popular in the treatment for a lot of these airway patients. So what are some indications for non-steroidal anti-asthma drugs? Well, the big one's going to be prophylaxis, right? Prophylaxis, right? Someone comes into the ER and they're working hard to breathe, right? Are we going to give them this type of medication class? We could, but that's not the primary indication, right? That's an acute situation. These are prophylactic. They're helped to stop that mediator release. They're designed to prevent it. And if you're already at that stage, you're well past the prevention area. So the big thing is going to be prophylactic management of mild to persistent asthma. So patients that mild to persistent asthma, this could be something very helpful to them overall. This is step 2 in their care, right? Step 2 in their care is going to be that prophylactic management. Cromolyn is one of the drugs in here. It's an alternative to an inhaled corticosteroid. So instead of doing just a flow vent inhaler, they can try something like this in step 2 asthma, right? But the big thing would be side effects. Infants and young children are the other consideration here as well. So this one can be used in infants and young children. But you do have to be careful of side effects like coughing, difficulty swallowing. They could have hives, itchy skin. They could wheeze. They could have swelling, breathing, so that allergic response. The most typically it's used in children over 12 years old. And then they can use it in infants 2 to 12 years of age. So it can be mixed and used in kids that are younger. But the big thing here, it's different from an antihistamine, right? These medications are different from antihistamines. They release histamines once the mast cells have produced it. Cromolyn is typically it's over the counter. You even see it in nasal sprays. I think it's called nasal crom, something like that, which helps with allergies. The blood-brain barrier, it does not cross the blood-brain barrier at all when we're looking at this, so there's no CNS effects from it. These are considered pretty safe, right? They're considered safe and effective, especially in adults. The most common side effect are just like the discomfort of a nasal spray or eye drops, or sometimes they can get headaches or other issues, but it is going to be one of those drugs that can help with a lot of these patients, and it does help prevent or treat symptoms like we see with sneezing, wheezing, running nose, seasonal allergies, right? Allergic rhinitis, right? It does help with those situations. So it's great for those allergic situations as well. When we're having this, the big thing is to understand when to use it and how it works, and this is not an antihistamine, right? The other thing that we see is the leukotrienes, or the anti-leukotrienes. The anti-leukotrienes are usually used in combination with inhaled corticosteroids. So obviously the inhaled corticosteroids to help reduce airway inflammation. When we're looking at anti-leukotriene drugs, they modify that leukotriene pathway, and they're antagonists, right? They're antagonists. So they're a group of medications that help prevent issues associated with allergies, asthma, COPD, montelukast, zafluricast, xyluten. Xyluten are the big ones here. When we're looking at these, they really do help modify that category, so that way it does help prevent those issues, and they do work well, especially when they're used with combinations of inhaled corticosteroids. Singulair or montelukast is one of the ones, or a colate, and we'll talk about those, are usually the ones that are used to treat asthma and allergies. But they can also be used to treat skin disorders too. So you'll see it out there for other things as well. But it's something to be aware of, other uses for it out there. So cromolyn is the first one. It doesn't allow the cascade, and that's the big thing to remember. It is a mast cell stabilizing agent, and we just talked about that a little bit ago. Mast cell stabilizing agent, and its primary use is for prophylaxis, right? It may take a couple weeks to take effect, just like inhaled corticosteroids. Inhaled corticosteroids usually take about 3 to 4 weeks before they're effective in their airway inflammatory control. So similar there. Remember, this is used for mild persistent asthma. The mode of action, it prevents mast cell degranulation, right? It prevents those guys from destabilizing and releasing all their bad things. The side effects here, and I already talked a little bit about it, was that cough, a little nasal congestion, they can wheeze, right? Nose is burning, right? Especially if they're doing the nasal version of it when we're looking at this. So here is that pathway that we're looking at here, and the whole point is it cannot stop mast cell degranulation once it has started. But the whole point here, and this is where I'm circling, cromolyn sodium blocks this, right? So once that antigen attaches to the mast cell then does nothing, right? It doesn't destabilize like it was supposed to do. If we stop that, then we stop the release of slow reacting substance of anaphylaxis and histamine, and so on and so forth. So it blocks this whole pathway down here, right? We have the antigen that goes into the airway. We have the antibody formation. The antibody attaches to the mast cell, and nothing happens, right? Because we blocked it, right? It was a good block, right? And that's what we're talking about. It's prophylactic. It cannot stop a mast cell degranulation once it has started, but it stopped it right there. The efficacy is pretty similar to theophylline when we're looking at this, but this one has a much better therapeutic margin. So that's why when I said earlier, we try to do cromolyn on your COPD asthmatic patient before going to a theophylline or a xanthine of choice. That's where we're looking at this because the therapeutic margin's much wider. It's much more effective there. We do use it in ACE inhibitors, right? ACE inhibitors, it can cause a cough as well. It has some anti-sickle cell effects, which should help reduce pain in sickle cell crises as well. And then what it does there is it reduces the number of sickled red blood cells. So it's pretty cool too. They'll see it in different scenarios. But the big thing, if we're doing this, is it's also an alternative for children, right? Kids can use cromolyn, but we need to remember to taper their corticosteroids, right? Their inhaled corticosteroids if we're switching, because it does take a couple weeks, just like inhaled corticosteroids. So let's say, give me an example, Derek, right? What are you talking about, all right? So if a kid's on a Flovent inhaler, which is a steroid, inhaled corticosteroid, well, we need to keep them using that inhaled corticosteroid while they're using this one, right, while they start this one, and then we need to make sure that they've been taking this one for a couple weeks, and then we can taper off taking the inhaled corticosteroid. So we need to make sure that we taper, right? We're tapering it because it takes a while to really build up in the airway to be effective. So remember, we need to taper the corticosteroids if we're switching. We're not just going to go Flovent to straight over to the other one because it's got to take time. So we need to taper that as well. And then especially, we can do this in combination with other drugs when we're looking at it for the sickle cell use as well. So when we're looking at these anti-leukotriene agents, when we're looking at them, there's leukotrienes and prostaglandins. And these are just groups of fatty acids or lipid mediators of inflammation that we're looking at here. So they're potent bronchoconstrictors, right? They're potent bronchoconstrictors, and they will cause airway edema, right? Mucus secretion, ciliary beat inhabitation, right? Inhibits the ciliary beat, and then it will recruit other inflammatory cells. Hey, I'm doing something bad. Do you want to join me, right? It recruits other cells into it. Boo, right? Just say boo, right? Not good, right? So these anti-leukotriene agents really do help stop this pathway of airway edema, mucus secretion, ciliary beat inhibition, and then the recruitment of inflammatory cells. It really does help prevent these when we give the anti-leukotrienes. So leukotrienes, this is what their job is. Anti-leukotrienes try to block the airway edema. They try to block the mucus secretion. They try to block that inhibition of ciliary beat. So that's the whole point here, is to use it to prevent all that from starting in the first place. And if someone's already in an exacerbation, then that's not going to be helpful or a helpful medication to them. These are synthesized after stimulus activities. So we're looking at the 5-LO pathway, and that's on the next slide. So pay attention to the next slide, right? You're like, I don't know what that is. I'm like, I just talked about it on the previous slide, right? I guarantee it'll happen, right? So when we're looking at this, we're looking at the leukotriene production, and then what happens here is they'll bind to the cis-LT receptors, and that affects the leukotrienes. So these will attract neutrophils, right? These leukotrienes will attract neutrophils. They love finding neutrophils. Okay, well, that's interesting. So here's your 5-LO pathway that we were talking about. Here it is up here. Here's the nucleus. Here's that stimulus. What happens here? We're releasing all these bad things through the cytoplasm, through the cell membrane. We're releasing all these factors, right? We're releasing all these factors, which causes chemotaxis and neutrophils, right? Which is causing our smooth muscle contraction, our mucus secretion, our vasodilation, our vascular leakage, right? Our eosinophilic recruitment. These are all those bad things that we were talking about on that previous slide. So you're like, I'm not a big fan of this picture, it looks too busy. Well, it's everything we've just been talking about. It's just in a picture form. But these drugs, these anti-leukodrying drugs, block binding to the cis-LT. They block binding to this one here. Here, let me use red. They block binding to this part here. They block binding to that part here. So anti-leukotrienes block. This is their site of action. They block that, which then should block that smooth muscle block it from having smooth muscle contraction, mucus secretion, vasodilation, vascular permeability, eosinophilic recruitment. It should block all this stuff because we're taking up that parking space and we're not stimulating it. Right? So these drugs, you're like, what drugs are in these categories? Well, they'll have the suffix Leucast, like Monteleucast. I love that name. I don't know. It's like the Count of Leucast, right? Leucast, L-U-K-A-S-T, right? L-U-K-S-T, right? So any of those Leucast drugs will block that site, which then should prevent smooth muscle contraction, mucus secretion, vasodilation, right? All that bad stuff there that causes the patient to work harder to breathe. That's what anti-leukotrienes do, is they block this area here, right? They're your friend in that anti-leukotriene drug category. Right? We just talked about, that was on the previous slide, was your 5-LO inhibitor, right? So you'll see drugs like a brand name versus generic name here. You'll see these on your drug tables. They block the CYSLT receptors, right? The CYSLT receptors, right? That's what we just looked at on that previous slide. So the leukotriene receptor antagonist is what we're looking at here. They're antagonists. They park in the parking spot and they don't allow the bad stuff to go in there. They park there, right? So you'll see this with the cholate. You'll see this with Singulair. You'll see this with Xolair, right? So you'll see these in these anti-asthma drugs, including your monoclonal antibodies as well. So it is important to go over these, and we'll go over them here in the subsequent slides. First one we'll talk about is Xylutin, also known as Zyflo controlled release, right? So you'll see this is Zyflo controlled release or extended release. These ones are oral tablets, so this isn't something that you nebulize, right? The mode of action is inhibiting the 5-LO enzyme. Hey! That's what we were just talking about previous two slides. The big side effects or hazards is the headache, right? Abdominal pain, loss of strength. But the big thing is monitor their liver function, right? Why? Because the dose is needed, right? It could cause issues there with how it's metabolized, right? So remember, what organ system is part of your metabolizing responsibility? Well, the liver is part of that whole situation. So we need to monitor their liver function. So we need to do things like liver function tests, right? So your AST, ALT, right? So we need to look at their liver enzymes during this when they're taking these. It does interact with theophylline and warfarin, especially if they're taking warfarin for like atrial fibrillation, things like that. So it increases the dose needed when we have their poor liver function and can interact with theophylline as well. And it can cause a higher chance of toxicity to the patient. So we do need to monitor their liver function. We do need to monitor these patients when they're on things like Xylutin or Zyflo. A cholate Ocolate on this one. This one is also an oral administration drug. You're not going to be nebulizing this. Please don't. That's not what it's approved for currently. The mode of action is the big point here. It's a leukotriene receptor antagonist. Antagonist, right? Hopefully you're circling that. It's an antagonist, so it parks in that parking spot and it won't allow the leukotrienes to go any further. The big hazard and side effect would be things like laryngitis, pharyngitis. Nausea is very common with a lot of drugs that we're talking about here, and they could be more prone to viral infections as well. But remember how their mode of action works. That does make sense that you would see these side effects. Singulair, right? This is one of the drugs that I used quite a bit. Singulair is a great one. It's an oral administration. It's also a leukotriene receptor antagonist. The big side effects are the same thing as your ocolate, right? You're going to have that laryngitis, pharyngitis, nausea, more prone to viral infections, things like that. And remember, these ones block the CYLST, right? They block that. They block that area. So they block it from triggering all that bad stuff. So when are these beneficial, right? So anti-leukotrienes are beneficial. They're good at controlling asthma, right? They're good at controlling asthma. Once again, not an asthma exacerbation drug, but a controlling drug. So if someone shows up to the ER in a severe exacerbation, this is not the medication category for them, right? They're well past that response, but it's good at a controlled baseline of asthma. These patients could be asthmatics that are triggered by exercise, aspirin-induced allergic responses as well. But the big thing is it's prophylactic, right? So it's prophylactic against all this stuff. So very, very beneficial against chronic persistent asthma, Chang-Strauss syndrome, which is unknown. It usually affects people 20 to 40 years of age when we're looking at this. And what happens there is it causes peripheral eosinophilia, and that eosinophilic infiltration of the tissues, and it causes a necrotizing vascularitis. So the tissue literally is being eaten. It's necrotizing. It's dying in the vasculature. So it can cause major organ damage, right? And so they have a lot of issues there. And so that's one thing that could really be beneficial to help with those patients, because it helps control those mediator pathways. And then in theory, it could be beneficial with RSV patients as well. But that we're going to see that it does help control asthma. So that's going to be the primary thing, is it's good at controlling asthma symptoms. Advantages. It's an oral administration, so pretty easy to take. You don't have to worry about cleaning any equipment. You don't have to worry about time. You don't have to worry about embarrassment of breathing through different equipment in public or anything like that. There are very few side effects. It's very effective, especially in aspirin and exercise-induced asthma, right? So they say asthmatics shouldn't be taking aspirin because that could cause that release, and we can talk about that pathway separately. But especially in exercise-induced asthma as well. It's very effective with inhaled corticosteroids. It really does help, because now we have the anti-inflammatory pathway on top of using this blocking pathway, this antigen blocking pathway. And then it's approved for pediatric dosing. So we can use these with small pediatric patients and still have a good quality of life for them. So it's a pretty cool advantage in that scenario. Some disadvantages, I have talked about this on previous slides. Disadvantage is the anti-inflammatory action is limited to just one mediator pathway. So that's one of the big disadvantages. It has variable responses as well. There is no predictor of the patient response. You can have systemic drug exposure as well, but generally it's not useful as a therapy by itself. It's usually going to be in combination with an inhaled corticosteroid. So an inhaled corticosteroid of some kind. So that way it's going to be almost synergistic, like what we talked about with our with our parasympatholytic presentation. So it's going to be more better. It's going to be better in combination. It works better as a couple than it does as a bachelor, right? It works better as a couple. So let's talk about Xolair. So this is Xolair. It has another name, but I'm just going to call it Xolair because I just want to call it Xolair. You're just going to have to deal with it. These are a subcutaneous administration. So Xolair is given subcutaneously. It's an allergy shot, if you will, very similar to an allergy shot when we're looking at this. The mode of action is what's called a monoclonal antibody. The monoclonal antibodies are a very interesting route of administration. Because monoclonal antibodies, what they do is this one specifically will bind to the IgE in the serum, and this will form trimers and hexamers, right? So what it'll do is it'll form to those, it'll bind to those, and it cannot bind to its receptor on the mast cells and the basophils. So if it can't bind to the mast cells and the basophils, then it's not going to cause that cascade. So the whole point here is to bind to that free IgE in the serum, and then it's going to make it unable to cause, ultimately, mast cell destabilization. So that's a really cool way of approaching it. The big hazards and side effects is it could cause anaphylaxis and malignancies. These are pretty rare. There could be injection site reactions, just like anything else, upper respiratory infections, and it's used for uncontrolled moderate to severe asthma. So you'll see this out there. The patient must be over 12 years old, and they must have a positive skin test, for allergen measures, right? And it's got to be specific to IgE, right? And so they'll have to have an allergy test traditionally, but the whole thing is it's blocking those binding receptors of IgE onto the mast cells and the basophils, so it's stopping it from ever causing the mast cell destabilization in the first place. So that's a good one here with Xolair, that monoclonal antibody. Finally, your respiratory care assessment of these patients. Remember, this category of drug is a controller, not a rescue agent. Not a rescue agent. Not a rescue agent. So these are controlling your long-term use medications. They can still use their peak flow meter, and the whole plan here is to look at their symptoms and the results of long-term use. On average, are their peak flows better after a couple weeks of use of these medications, and so on and so forth? So that way we can sort of see what their symptoms are and the results really are versus like, how do you feel? Well, that's one way of doing it, but like now we can see trending data of how they are doing afterwards. The long-term use, we can see their severity of their symptoms. Are they having as severe symptoms or not as severe? Are they having more or less exacerbations? Are they visiting the hospital more, or are they visiting urgent care more, right? Are they missing less days of school? Are they missing less days of work? What do their pulmonary function tests show? Is there less obstruction on their airways? Is there less inflammation? Is there exhaled concentration of nitric oxide lower, right? And then side effects, right? We can see, do they have any significant side effects that they're having with the medication? Should we try a different drug within these categories of non-steroidal agents as well? And then do understand, like I was saying before, a lot of times these drugs are in combination with an inhaled corticosteroid to help with them. They're not great at working by themselves traditionally. So hopefully you got a lot out of this. I know it was a long lecture, but understand, make sure that you go through and try to summarize some of the main points. and understand some of those big concepts and where you would see it, when you'd use it. What situation are we going to use Xolair in? What situation are we going to use cromolyn in? What situation are we going to use xanthine in as a first-line therapy? What situation are we going to use a xanthine as a second or third-line therapy? Where does cromolyn come in when you're treating COPD? Does it come in before xanthine or after xanthine, right? So start going through these things and thinking through these scenarios. When are we going to use it? What symptoms would we see? What are some of the drugs in those categories?